While people are setting up, I will encourage you to fill out your evaluations, and I will thank AbbVie for their generous support for this session, as well as the steering committee, Dr. Saint-Sardas, who's here, Dr. Deschênes as well. If there are no questions, I'll leave my seat up here for you. No questions from the room so far?
Where would you put the acupuncture needle?
We're used to putting him in the eye now.
Well,
So.
you mentioned acupuncture.
Yeah.
Were you serious?
The question from the room was about acupuncture.
Yeah, I was just speaking in general about forms of multidisciplinary cares, not necessarily for the eye conditions, but acupuncture could be used in treatment of musculoskeletal or neurological diseases.
Serious?
Well, I'm not the acupuncturist, I would not know where to put it, but our patients very frequently go to see those, non-conventional specialists and report benefit from receiving non-traditional care.
Yes, there's another question back here.
Question for Dr. Kurani. You talked about uveitis that could be induced by injection of anti-VEGF because of the formation of antibodies. What is the typical onset after injection? Is it like a few weeks after the injection that they develop uveitis, or?
Yeah, it's a great question. I think most of these injection-induced uveitis, drug-induced uveitis, occur quite quickly. So if you have an inflammatory response very immediate after the injection, it's very typical of it being inflammatory, whereas the infectious agent, infectious endophthalmitis, may take 3 or 4 days to develop. So the allergic or inflammatory reaction would typically occur quickly.
Thanks.
And
I just want to comment, I do have a patient who decided to have acupuncture for glaucoma, and the acupuncturist perforated the eye and very quickly treated the glaucoma.
Can we run over for a minute or two? So maybe just one encompassing general question that's open for everyone. So macular edema is really something that we all hate, and it's difficult to treat in uveitis. So can anybody or a few of you give us your treatment algorithm for how you think of treating uveitic macular edema? Perhaps Dr. Kurani, since you were starting with that.
So generally, I try to make the eye quiescent with steroid treatments, locally or systemically, steroid-sparing agents to help reduce the steroid side effects. And most times that will treat the macular edema. If you have refractory macular edema that is not responsive in a quiescent eye, then I have used the anti-VEGF treatments.
Okay. Have you used topical therapy, or there's some talk of difluprednate now sometimes being effective, NSAIDs, things like that?
Yes, so topical steroids, also non-steroidal topicals have been, I try those also.
So certainly that would be the first line of treatment, but there's one setting where we all have a big challenge, which is those patients that have posterior segment disease like birdshot, and they have chronic macular edema. And in those settings, sometimes you have a patient who's already on a history of oral corticosteroids. You don't want to start it again. They've been on immunosuppression. Maybe they're on a little bit of methotrexate and they have a biologic on board. So what do you do in those cases? So we're not going to be reaching for topical therapy at that point. So certainly intravitreal injections of steroid, periocular injections, but sometimes increasing the biologic agent can help, and we know that Remicade is a good one for treatment of macular edema. There's a little bit of evidence for that.
I'd like to just caution also with the difluprednate. It causes pressure rises very quickly, so these patients need to be followed very regularly. So I usually start with topical prednisolone and a non-steroidal anti-inflammatory for CME in conjunction with other treatments. So even if they're on immunosuppressives, if they have CME as well, I will add the topical drops. I think there is some benefit. If I use Durezol, then I see patients every 2 weeks, or at least I have them see their optometrist every 2 weeks, because you can get a very sudden pressure rise. Even if you don't see it initially, you can see it 2 months out, and it's really not a sustainable treatment. So if patients have to be on Durezol for difluprednate to manage their CME, then you should be thinking about what else to put them on. So whether it be occasional injections, posterior subtenons, intravitreal, or whether you need to maybe consider switching to an anti-TNF agent.
Okay, what about Ozurdex?
Well, sure, yes. So I guess that goes in my category of injections,
Yeah.
and absolutely that would be a good option, especially if patients have it doesn't induce as high a pressure rise. So yes.
Yeah, it doesn't cause that much pressure rise, but Ozurdex might be a choice. But I think you have to differentiate between active disease with uveitis or uveitis that is burnt out where you have persistent macular edema, and there are cases like that. So if you're getting into that latter group, Ozurdex might work, but you're going to be chronically injecting Ozurdex in these patients. And so there, trying interferon in some patients works very well, and it doesn't matter whether it's alpha or beta. You need to treat them with paracetamol. I have to think always about the name, Tylenol here, in order to be able to control the flu-like symptoms and be aware that they may become depressed. And there are people that have tried to commit suicide, but that can also happen with some of the other drugs we have. And there's still one other alternative which has been described. In fact, Steve Foster also published on it, and I've used it, is to use a growth hormone analog. So that's completely off the beaten path. But there are 5 different receptors for growth hormone, 3 of which are present in the RPE. And if you stimulate it, you can get rid of macular edema, and it's also a subcutaneous injection.
There's also tocilizumab that's coming out right now. That's for that type of situation where a patient has, a non-responsive macular edema, I have used the fluocinolone implants occasionally in a patient that was actually hypotenuse as well. So glaucoma wasn't an issue. So it's available here in Canada, but it does cost $18,500. So
but as compared to every 4 months injections of Ozurdex, I think it's a good alternative. And if you can restore vision, it's very often a single eye, or they've had it in both eyes. It's worth it. You can increase vision by 2 or 3 lines sometimes.
So I think we're going to have to wrap it up because we're already 5 minutes over. But I'll thank every one of the speakers here for taking time to come up and give some excellent talks. And thank you all for being here early this morning.